What I wanted to do with my session was to give you some practical walkthroughs of some of the families that we've been dealing with in Edinburgh. Obviously, I'm not going to talk about individual real families, and these represent perhaps more of a composite of views and experience, but I think that they are realistic examples. And secondly, I was asked by Jane if I could touch on saviour siblings, and I'm going to explain a little bit again about the practicalities of PGD for single siblings, rather than getting involved in the ethical discussion around saviour siblings, because I think sometimes it becomes an ethical debate when perhaps actually there's a huge practical debate that hasn't been had before you could get anywhere near making an ethical decision on it. So cystic fibrosis is the commonest single gene disorder that we receive requests for pre-implantation genetic testing. And most people in the room, I think, will have a very clear picture of what cystic fibrosis is. It is our commonest severe autosomal recessive disorder characterised by chronic lung infections leading to lung damage, and usually also pancreatic insufficiency with significant digestive problems associated. I'm quoting a life expectancy around 35 years there. The thing about cystic fibrosis is, although it's one name for one disease, it is actually a huge spectrum depending on the underlying genetic pattern causing cystic fibrosis. And there are desperately sick children with cystic fibrosis, and there are adults who are holding down jobs and managing to live a normal and productive life. So it's, even cystic fibrosis as a classical autosomal recessive disease has its own issues in trying to understand what it is. So just to remind you briefly about how cystic fibrosis is inherited, we've got two healthy parents here. This cross shows where the cystic fibrosis gene is not working. So each of these parents is a carrier of one faulty copy of the cystic fibrosis gene. There are four possible outcomes in a pregnancy. Mum can pass on the good copy, dad can pass on the faulty copy. That would be a healthy carrier. Each parent could pass on the healthy copy, and that would be a healthy non-carrier. Each parent could pass on a copy of the gene that isn't working, and that would be an affected child, or there could be a carrier that's got a healthy copy from dad and an affected copy from mum, another healthy carrier. So this is a fairly typical family that has been over to see us in Edinburgh in the past year. John and Lynn have a daughter, Maggie. Maggie is 3 years old, and she suffers from cystic fibrosis. She was detected very early on because, as you know, we now have a newborn screening programme for picking up children with cystic fibrosis soon after birth. And so she has had optimal care. And Maggie is generally, she's needed quite a lot of hospital support, but she's doing all right. And interestingly for John and Lynn, their major issue about having a child without knowing the status, the risk of a second child with cystic fibrosis, was for Maggie. And this is something that I suspect, Margaret, you're hearing a lot as well. For families with a child with cystic fibrosis, the thought of having a second child that is also going to have a series of infections, perhaps with pathogens that are quite hard to treat with antibiotics, that might infect the child that you have, is a major issue. So for this family, they felt that it was totally unfair to Maggie to risk another child with cystic fibrosis. And because of their experience with Maggie, they felt that termination of pregnancy was also not an option for them. They felt that it would be rejecting Maggie, and they didn't want to do that. So they had a very clear plan about why they wanted to have PGD. Now, this, you wouldn't see even if the lecture theatre had a giant screen, but what I've put this up is just to give you an idea of the complexity of looking in PGD for single gene disorders. You'd think that if we knew what the gene fault was. We could just look at the gene fault. But in fact, it doesn't work like that when you're working with a single cell. You've got to characterise the pattern of the area of the chromosome around the gene. And I'm going to show you why in the next slide. So what we do in the lab is we run lots and lots and lots of different tests to characterise, first of all, the pattern in mum, then the pattern in dad, then the pattern in Maggie. And we say, oh, well, this is the chromosome that mum's passed on to Maggie. This is the chromosome that dad's passed on to Maggie. So this is the pattern that we're looking for as the affected pattern. What do we get in the embryo? So here we have embryo number 1, which has inherited mum's green copy, which is the low-risk copy, because the red copy is the one that Maggie has, and has inherited dad's blue copy, which is the high-risk one, because that's the one that Maggie has. So this is a carrier embryo. So first question is, do we distinguish between carrier embryos and embryos with 2 normal copies? Well, no, we don't. What we do is, our aim is to maximise the chance of a healthy baby being born to this couple. So what we want to do is to put back the best looking embryo. So when talking to the couple, it's not about this is unaffected, this is a carrier. This is an autosomal recessive disease. We know that if this embryo here turns into a child that's a carrier of cystic fibrosis, that's not going to cause them any medical problems. So we feel we just go for the best chance of a healthy pregnancy. So why don't we just directly look for the mutation? That'd be a lot easier. Say yes or no, is it there, the cause of the cystic fibrosis? Well, the problem is that we're dealing with one single cell, and all sorts of things can go a bit awry in the lab. You could get contamination, and you've seen from Margot's pictures how you're taking off, how the egg is obtained, the sperm is obtained, you're taking off on a sample. You just need a tiny, tiny, tiny bit of DNA from anywhere else, and that could contaminate the test. If you got anything from mum or dad, potentially you could get false positive results, because you could pick up their faulty copy when it wasn't actually there. There's also something called allele dropout, which relates to the fact that this test is right at the cutting edge of technology, that you fail to amplify up the mutation. So you don't see it because you've not managed to demonstrate it's there, and then you get a false negative result. So we, along with the vast majority of other labs, opt for this rather time-consuming patterning called haplotyping. So what happened to our family? And this again, this is very typical of what we're getting at the moment. Collected 6 eggs, and you see all the way through we're going to be sort of losing something. 5 of those eggs fertilised successfully. So we were able to get them to an embryo stage where we were able to biopsy them and actually look at the cell. And out of those, we managed to get results on all of them. 3 of them were carrier embryos, which we called unaffected. 1 was an affected embryo with 2 high-risk copies, and 1 was an abnormal embryo. And I don't know, Scott maybe talk about this a little bit. When you're looking at very early embryos, there's quite a lot of very odd stuff going on as well that really would not be going any further. So we had there 3 potential embryos that we could put back. So in conjunction with the embryologist, who's the person that can look and say, yes, that embryo, that's the healthiest looking embryo, we chose which embryo we put back. And we have had a successful cystic fibrosis PGD pregnancy. Unfortunately, this one, despite having 3 embryos at that biopsy stage, by the time we were looking to freeze the embryos, because ideally we don't throw any good embryos away, because obviously if this cycle doesn't work, that couple is going to want to come back. So we conserve all suitable embryos by freezing them, but there were no embryos suitable for freezing. So we just replaced 1 embryo, and that was it. That was the end of that cycle. But fortunately, she became pregnant, and we were able to confirm when the baby was born that the baby was a carrier. as we predicted and not affected. So that's the sort of pattern of cystic fibrosis. You see, there's quite a dropout at all times. And whilst you think, only 1 out of 4 embryos should be affected, we're not necessarily getting a whole load of unaffected suitable embryos to put back. Now I wanted to consider a different disease, and this is actually our second commonest cause for referral. This is quite different. This is Huntington's disease. Again, I suspect you all know all about Huntington's disease. It's an autosomal dominant disorder, which means that if one of your parents has it, there's a 50-50 chance that you will inherit the faulty gene, and then you will go on to develop symptoms. Symptoms develop late 30s, early 40s classically, but again, it's like cystic fibrosis. You can have one classical picture, but you can see a full range with Huntington's. You can see Huntington's coming on tragically even in childhood. You can see people in their mid-70s unsteady on their feet that when, as part of their investigation, turn out to have Huntington's disease. So again, it's difficult to give a classical picture. But generally, for families with Huntington's disease, this is a very significant burden, and the thought of being able to prevent it happening in future generations is very important for a proportion of families. So what I have here is a sort of example of what the options would be. So we have Dad here. Well, this is just Dad. And Dad up at the top has Huntington's disease. Now, we've put a wee star, meaning we've tested Dad and told him his result. So Dad knows that he's got Huntington's disease. His daughter Jane, who is in her 20s, had come to see us prior to starting a family, thinking, well, let's see if I'm actually at risk, or perhaps I haven't inherited it and I can dump all these geneticists and get on with my life. But unfortunately for Jane, Jane has inherited the Huntington's disease gene. So Jane is healthy, she has no features of Huntington's, but she knows the future. She knows that she is going to develop features of Huntington's disease. So she comes to see us, she says, I know I'm going to get Huntington's in the future, but we want a child, but I do not want that child to go through what I've been through. So we can do a test using exactly that same haplotyping strategy. We get blood from mum and dad. We work out that the Huntington's gene is on this blue copy here. So we can do the same sort of testing we did with cystic fibrosis. Do we see this blue copy, and we do in embryos 1 and embryos 3, or do we see the red copy, embryos 2 and 4? So embryos 1 and 3 have inherited the Huntington's faulty gene, and embryos 2 and 4 have not. So our choice for implantation would be from embryo 1 or 3 out of this arrangement. So yeah, sorry. Yeah, I'm just saying, just as well it's not me that does it. Embryos 2 and 4. So that's very straightforward, but as you can see, the odds again here are not brilliant. This is a 50-50 before you start, and then you've got the odd embryos that are not suitable to go back. So it's an option, but it's not an easy option. Now let's say, and this is the same family again, that Jane is in her 20s, her dad has Huntington's disease, she doesn't want to have a baby with Huntington's that's going to develop Huntington's as an adult, but she doesn't actually want to know if she's going to develop Huntington's in the future. She wants to maintain optimism but not take a risk with a baby. And actually this is our commonest scenario. These are the couples that are predominantly coming to the clinic. So they're couples where either the male or female partner is at 50% risk of Huntington's disease. They don't want to have a Huntington's test themselves, but they want to exclude the risk for a baby. So how do we do that? Well, the big difference between the two slides is you'll notice that the star is missing on on these two black bars. We've not got a star anymore. And that's because we've taken the actual Huntington's faulty gene out of the discussion. So we're not looking at the actual gene pool. We're just saying Dad's got 2 copies of chromosome 4, the chromosome that the Huntington's gene is on, and Mum's got 2 copies of the chromosome 4 that the Huntington's gene is on. Which chromosome 4 did Dad give Jean? So we're not saying, has Dad passed on the one with the faulty gene on it? We're just saying, which one is it? It could be his good copy, it could be his faulty copy, but can we recognise the one from Dad? So we run the tests in the lab that can tell the difference. So what we now know is that this black copy came from Dad and the red copy came from Mum. We don't know anything about this black copy. We don't know if it's got the Huntington's faulty gene on it or not. We just know it's from Dad. So that's the one that we're concerned about, because Dad's the one with Huntington's. So Jane will pass on one of these 2 chromosome 4s to any child. And so if she passes on Dad's copy to embryo 1, we don't know if that means that embryo 1's going to develop Huntington's, but we know that's the one that the risk's with. So that's in a way no news. It's the same risk as Jane. Embryo 2 here has inherited Jane's red copy. So that's the one that came from her mum. So that's the low risk copy. So again, we're in a 50-50 scenario, but this time we don't know if these embryos have Huntington's or not. We just know they're at risk. So again, embryo 2 and 4 would be the ones that we would select from. So that's called prenatal exclusion testing. Oh, is this a pointer? I'm probably just getting past pointing. So these are our 2 main scenarios. We're also seeing people coming through at risk of a boy with Duchenne muscular dystrophy. As Margot says, some of these families have been able to opt for fetal sexing, so they've been able to choose to have a girl with PGD through the Glasgow service looking at the chromosomes. But now we can take it one step further. We can actually see, is that an affected boy or not? So they have the option of also being able to have a male pregnancy. So I hope that makes sense, because I'm sort of switching now to talk a bit about saviour sibling for people that don't know what saviour sibling is. So this is my definition of a saviour sibling. So for me, a saviour sibling is a child conceived with the intention of using stem cells retrieved from the umbilical cord at birth to treat their brother or sister who suffers from a specific medical disorder. Now, the issues here are retrieved from the umbilical cord. So there's the ethical issues about conceiving a child for a particular reason, but there should be no pain and suffering involved in being a saviour sibling under these situations. This is taking blood out of the umbilical cord at birth. So this is not something that hurts the sibling, as long as it works. And then the other important thing is the specific medical disorder. Saviour sibling as a concept only works for conditions that can be cured or significantly treated by marrow replacement. You can't use a saviour sibling to treat cystic fibrosis, for example. It's a very particular set of predominantly blood-based and immunological disorders. These are the currently licensed, HFEA licensed conditions for which saviour sibling are allowed. So, if you want to be a saviour sibling, the embryo must have a very similar HLA pattern to the affected child. Now, basically, the way our bodies work is we have an immune system that recognises what is us and leaves it alone, and what is foreign and attacks anything foreign. So it's a system designed to manage infection. So if you get a bug, then your body goes, wait a minute, that's not Mary Porteous, out. And the way it does that is through a pattern of antigens on the surface of the cells, predominantly coded for by the HLA complex. So if you're going to transplant stem cells, those stem cells have got to result in mature cells that have a very similar HLA pattern, or the body's just going to go, get out, and they're going to be no use. So that's why you go for siblings and not just sort of a random baby's stem cells. The embryo must be free from the condition affecting the sibling. I mean, well, that makes sense, but that's why you've got this PGD step in save your siblings as well, because obviously there's no point in giving stem cells from a baby with the same disorder, because you won't cure it. And the condition must be treatable by stem cells. So HLA typing, basically it works very like the cystic fibrosis diagram I showed, that you get, this hasn't, unfortunately my slide has mutated. Can you look at this one here, there's an A11, A12, B4, B5. One pattern is A11, B4, and the other is A12, B5. And we've all got multiple different patterns here, but basically your HLA system predominantly is inherited in an autosomal recessive way. So basically a saviour sibling should have a pattern compatible with the other, with the child to be saved, so it'd be 1 out of 4 options. So I think if you're doing the maths and you're looking at my cystic fibrosis example and you're thinking 5 embryos, 3 suitable, and that's just for the first thing, and then you add in a 1 in 4 success, you can see what my problem with the saviour siblings is. Basically, there is a 1 in 4 chance that siblings will share a sufficiently similar HLA pattern at the HLA locus. So if there's a 3 out of 4 embryos with an autosomal recessive disease, theoretically should be suitable to put back. Good, faulty, faulty, good, faulty, faulty, good, good. 3 out of 4 are suitable. But if you put in the HLA typing and only 1 out of 4 embryos would have the same HLA pattern, you're reducing your success rate purely genetically to 3 out of 16 before you start looking and seeing that the embryo isn't suitable, there's something else going on. So given that only, as Margaret was saying, between 20 and 30% of embryo transfers will result in a birth of a baby anyway, you're putting a major extra step in there with the HLA typing. And if you actually read the accounts of saviour siblings, which are quite a big thing for sickle cell disease in America, and you look at the number of cycles, and again, probably from Scott talk, it's the level of stimulation as well to get maximum numbers of embryos. And these women are going through several cycles to get their saviour sibling. It's not something that you can just do on the side, oh, you're typing for thalassemia, could you just do the HLA as well? This is a big extra, and it is several different cycles. So basically, more PGD cycles would be needed to save your siblings. So it's not surprising that this is still sort of at the early stages to me. So I'm going to stop there. Any questions about the fact that anything else silly I've said?